Good afternoon, everyone. Welcome to the second annual session that we set up in the UK for PALB2 carriers and their families, where we'll provide you with information about developments and the gene mutation, new therapies, and how we're supporting families and the carriers themselves through their journey. So today I'm very excited that we are running the second event now. The first one, I would like to refer everyone to a session we ran on the 24th of September last year that's available on YouTube, and it will give you detailed information about the gene itself. So today we're not going to be covering that in more detail than last time, so please do refer to the YouTube recording. Mark, if I could ask you to move to the next slide, please. So the session will provide, as I mentioned, new updates on the international guidelines that will be covered. We'll talk about the new treatment options, understand from those of you who are part of the PALB2 Warriors group, and expect quite many of you are there. There were some questions that I posted as a patient representative, and everybody was very interested to know what's new on the horizon in terms of treatment and PARP inhibitors. And in the UK, we also developed a booklet about PALB2 that will get covered. And this time we are allocating more time for Q&As. Therefore, the main presentation will run for about 30 minutes, and you will see it on the agenda. And we're allocating quite a big chunk of the time for any Q&As that you will have. And I'll cover how to do that in a few seconds. If Mark, you could perhaps move to the next slide. Okay, so who's our panel today? My name is Yulia Baynham. I'm a PALB2 carrier, and I'm a chair of today's session. Very excited to have the best medical team that we have, world class today. So I'll start with Professor Mark Tishkovich, who is our founder of the PALB2 group, lead genetic specialist for this gene globally, and he connects with the other territories and countries. I was going to mention geographies, sharing the experience in creating the unified guidelines for PALB2. We have Professor Andrew Tutt, who is a global expert in BRCA1/2 gene, PALB2, and triple negative breast cancer. He is a director of the Breast Cancer Now Toby Robbins Institute of Cancer Research and the Breast Cancer Now Research Unit at Guy's Hospital. Also, we have Jen Wiggins from Royal Marsden, who is a senior genetic counselor. And on the panel, but for any Q&As, we'll have Dr. Andrew Kulkarni, who is the lead for Cancer Genetics Centre at Guy's Hospital, Guy's and St Thomas's Hospital in London, joined with by her colleague, Dr. Vishaka Tripathi, who is also genetic consultant at Genetics Centre at Guy's Hospital. So if I can proceed to the next page, and you'll see the timing for the sessions. Mark and Andrew will have 10 minutes each to provide updates on international management of international guidelines for PALB2 management, targeted therapies, and Jen will talk about the booklet, and we'll have the Q&As, as I mentioned, with everyone, with Andrew and Vishaka providing a response where it will be touching the areas that they're covering. And for the ground rules, which is the next step, so I wanted to say that this session one has been recorded, as you will see. We will not be recording Q&As because they're personal to every participant. So the recording will be 30 minutes for the main session, which will be posted through PALB2 interest group website and available to view through YouTube too. We will respect privacy and confidentiality through the Q&As. The event is aimed for the UK carriers, as you've noticed, but however, we are welcoming all the international participants too. But because of the panel, you will see that we will be referring to our National Health Service guidelines and other developments from the UK perspective. So just be mindful of your questions. If they're to do with practice in a different country, we may not be able to comment on that. You may need to refer to a specialist. And also we will not be, for the Q&As, again, be mindful if you have a specific concern and case, personal case, we will not be able to provide personal advice, but we will be able to cover your questions through the generic guidelines that are being developed. That's it. So I think that's kind of the main things I wanted to cover. In terms of Q&As, please do put them through the chat box that we've got here, and I'll pick them up with Vishak and others through the session, but we'll start answering them towards the end of So please, perhaps I would suggest if you could listen to the whole presentation first, because you might have questions we might be covering later, and then we can cover them at the end. So with that in mind, I think we will start off with you, Mark. We covered here.
Thank you, Yulia. And good evening, everybody. Thank you for the introduction. So my name is Mark Tishkowitz. I'm going to talk to you today about international guidelines that we have recently published. I'm going to walk through them with you. So these were published in May this year, and it was the result of a very large international, or a very fruitful international collaboration, essentially, of a number of different people. So this is the core group, and you can see that. So I was one of the leaders of this, together with my colleagues Doug Stewart and Tia Powell in the US. And so we were the key coordinators for this, for these guidelines. And then we invited a number of other specialists onto this panel. And what we were trying to do was make it as international as possible. And sometimes that can be quite difficult to do. We also were doing it under the guidance, or under the rules of the American College of Medical Genetics and Genomics. We thought that would be a good place to do this, because they have a good structure for developing guidelines, and also if we did it as part of a US body, then that's likely to be accepted elsewhere as well. So there are some advantages and disadvantages of doing this. Firstly, it was truly international, because we managed to get experts from US, Europe, and Australia as well, and Singapore. That meant that we had quite different perspectives on things. We had different expertise. It was a rigorous process because it was approved through the American College of Medical Genetics. We also had a clear timeline in which we had to produce this, again, because that was driven partly by the college themselves, because once they approve something, then they expect you to actually deliver on it fairly quickly. So we couldn't hang around. We had to, get on with it. And it was also well publicized by the college as well. So we've had quite a lot of press coverage from that, certainly in the more specialist, clinical oncology press, for example. So that's been very helpful. Downsides are lots of Zoom meetings at unsociable hours, because this was being done across many different continents. So I think the Americans got fairly lightly. They had normal hours, but then we were doing this sort of towards the evening. And our poor colleague in Singapore was having to get up at 5 a.m. in the morning for these calls. So she really did draw the short straw on this. Different healthcare systems are involved, so that does bring different perspectives, because different healthcare systems have different amounts of resource. It was quite a rigid process, because these are, we had to go through a number of different hoops that have been dictated by the college. But again, that lends itself to the importance of these guidelines. We also have limited data to work on. PALB2 is not such a well-known gene as others, such as BRCA1 and BRCA2, and that can create issues. But on the basis of that, we did have to fudge a few things and make compromises. And I've got a little logo here. So one of them is only a little bit of fudging, and 3 of them is a lot of fudging. You'll see that on different slides, basically. Okay, so one of the things that we did discuss quite extensively was whether or not where does PALB2 fit in the landscape of predisposition to breast cancer? And as you can see from this slide here, it sort of sits quite in the middle between BRCA1 and BRCA2, which are the well-known high-risk genes that most people have heard of now, and so it comes in between those, and then what we call the lower risk genes, CHEK2 and ATM. And you can see that there are some women who have PALB2 mutations who would actually fall into a higher risk, whose risk overlaps with those in BRCA1, 2, and there are others who actually would have quite a low risk, and that would be down here. So the spectrum is quite broad, and that will be defined by other things such as family history, and also importantly other things like polygenic risk scores, which we're not doing routinely yet in clinical practice, but we aim to implement over the coming years. So our first recommendations for breast cancer were that we should be using personalized risk estimates. So for example, there's a program that we use called CanRisk, which has been developed to enable us to incorporate other risk factors such as family history and lifestyle factors as well, such as number of children that a woman's had. And all these things can make a very small difference to the risk, but we can include these in CanRisk to come up with an individualized risk for someone. And we also agreed that PALB2 patients should be offered similar surveillance to BRCA1 or 2, and that should be modified according to individual risk, essentially. So we'd offer a similar, whatever was offered to BRCA1, 2 should also be offered to women who have PALB2 mutations. And a question comes up often, should one have a preventative or risk-reducing mastectomy? And the agreement was that can be considered as an option, but it is guided by personalized risk assessment. So if someone's risk actually comes out lower because they don't have a family history of breast cancer, then having a preventative mastectomy may not be the route for them to go down. It may not be the correct route. One of the questions that we get asked a lot, and unfortunately we have very little data, is if someone's got breast cancer and they've got a PALB2 mutation, what is the risk to their other breast? So what's the risk of them getting a new breast cancer and the other risk? And we're not talking about getting a recurrence of the existing cancer. We're talking very specifically about a new cancer. And in that situation, we don't actually have any figures to give someone because we don't have that data yet. That requires further studies that are ongoing at the moment, and we will have that data in time, but we don't have it just yet. So here we really didn't have much to go on. So this was really quite a big fudge for us, I think, really. And we said, given the lack of data on this risk, we essentially have to look at the current circumstances and think about what other risks there are for that person. So, for example, if they've got a poor prognosis breast cancer, it may be more important to focus on treating that first rather than thinking about having a preventative mastectomy for the other breast. So these are...
I suppose it will be quite difficult to carry with the research. If people having mastectomies, then they won't be able to be surveyed. So if they're having preventative mastectomies, yes, then they aren't going to contribute to the data. But many women will just opt to have a lumpectomy for their treatment, and then we will follow them up, later on beyond they can then be followed up. So you're right. If lots of women have bilateral mastectomies when they're diagnosed with breast cancer, then we won't get that answer very anytime soon. Another key question was relating to the ovarian cancer risk in women who have PALB2 mutations, and there are some data on this now. So this is one study that was published in 2020, and there's a second one as well here. So the one on the right is the one that I was involved with. The one on the left is from other colleagues, and we used slightly different methodology for this. But you can see it's important to look at the scales here. So we're looking at this only goes up to 6%, and this goes up to 10%. And I've tried to magnify the one on the right. So the scales, they broadly meet at 5%. You can see the cutoff. So they're broadly comparable here. And you can see that one study estimated the lifetime risk of ovarian cancer to be about 3%, and the other study estimated it to be around 5%.
So these are quite modest risks for ovarian cancer. Importantly, the risk below the age of 50 on both studies was pretty low. I mean, it's certainly less than 1% here and here. So these are the data that we have to go on at the moment. These are both studies still based on quite small numbers, but it's reassuring that they've used different methodologies, and we've got some ballpark figure now, which is somewhere between 3 and 5% for a lifetime risk of breast cancer, and certainly a value of less than 1% for a lifetime risk of ovarian cancer, and a value of less than 1% for a risk of ovarian cancer to age 50. So using these data, we said that risk reducing oophorectomy, so removing the ovaries, should include shared decision making. So because the risks are still quite, are not so high up to the age of 80, it may not be warranted to actually go down this route. And it should only rarely be considered before the age of 50, because then you're dealing with premenopausal women, and removing the ovaries in the premenopausal women can have longer term complications, because you're introducing a menopause at an earlier age than normal. So that was the agreement that we came to. The other key point was that we were strongly advised was that ovarian cancer surveillance, so ultrasound and or CA125, which is a blood measurement, should not be offered, because there is now very good evidence that these do not work in terms of picking up ovarian cancer at an early enough stage to make it treatable. So there isn't any ovarian surveillance, unfortunately, but we do have some guidance now about what we should be doing when we're thinking about surgical prevention. And we also came on to pancreatic cancer risks, and again, the risks are quite small. You have to be mindful of the numbers here on these graphs, and we have different risk estimates for male and female. But you can see that neither of them are really getting above the 2 to 3% lifetime risk here. So these are quite modest risks for a cancer up to the age of 80. And here we actually had a sort of I think we agreed to disagree to some extent, because there's a more proactive environment for surveillance in the US compared to other countries such as the UK. So the statement that we made was that although the US surveillance for pancreatic cancer is encouraged, in the context of surveillance study, the position in the United Kingdom is based on the lack of data. Excuse me. Thus, surveillance is not recommended. So we would not recommend that routinely, and we would only offer it in the context of a research study in this country. And that's because the evidence is really not there at the moment for this. In terms of it actually, it's one thing to detect cancer. It's another completely different thing to detect cancer early enough to make it treatable and therefore to save someone's life. Therapy, I'm going to touch on this briefly because Andy Tutt is going to talk about this in his talk, but there is some evidence of increased response to certain agents, which Andy's going to talk about in his talk, and that PALB2 is very similar to the BRCA1 and BRCA2 genes here in terms of response to drugs like olaparib, for example. So we felt that given and we know looking at the cell data, when you're looking at the cell biology data, that PALB2 behaves, PALB2 cells without PALB2 have a very similar behavior to those that don't have BRCA1 or BRCA2. So we felt that given the mechanistic similarities here between PALB2 and BRCA1 and BRCA2, patients should be considered for the same sort of therapeutic regimens and trials as those for BRCA1 and BRCA2. But we're using very careful language here. We're using words like considered, so we're not, these are not absolute recommendations. These are really guidance. And I think that's an important point, because this will vary very much from country to country, and it will vary according to what resources are available. But that is broadly the sort of advice that we would be giving for this. We also had a discussion about what to do if one person is a mutation carrier, should their partner be tested for it? Because there is this risk of Fanconi anemia, if, you know, by chance, in the very rare situation that both the mother and the father have a PALB2 mutation, there's a 1 in 4 chance of having a child with Fanconi anemia. This is incredibly rare. There's only a handful of cases like this known worldwide. And because it's so rare, we didn't think that it was justified to routinely test partners of people who have PALB2 mutations, who are thinking about having a family, unless there's a very strong history of cancer on that partner's side, and there could be a suspicion of a PALB2 mutation. But in general, we didn't think that was a helpful process to go down. So those are the key summary points from this discussion. Everything's available online. This is the title of the paper. You can download it from here. It's also available from the website. So, you know, you're very welcome to have a look at it and read it in your own time as well. Just to say that to do sort of studies such as looking for the risk of a second breast cancer, we are encouraging people to who have mutations to join a UK-wide study called Embrace, where we'll be monitoring them going forward, and we can then see who develops a second breast cancer and who doesn't. And this sort of study that will give us the answer as to those questions. Please also check the PALB2 Interest Group website for updates and including links to this paper as well. And we're also going to publish, this process went so well, we're going to carry on and look at some other genes doing it. So overall, it went well. Thank you very much for your time. That's the end of my
Mark, I just got a couple of things to ask you. For UK participants in the call, these international guidelines, have they been fully implemented within the NHS system? So everywhere you go in the country, it's guidelines now, or not?
Yeah, no, not yet, no, because these are guidelines that are published, and this is guidelines are guidelines essentially. So, you know, they're not, we can't oblige people to follow them. Okay, this is basically a paper saying, well, this is what we think is best, but we also accept there's some limitations to this because we don't have data in certain situations. So this will not get implemented in the NHS in any systematic manner. It's not that sort of scenario, if you like. The way to do that is to go through something like the NICE organisation, which is which is the NHS body or the national body that looks at quality of evidence. But I don't think they'll be looking at this anytime soon, because that's such a big body. And this is quite a small, as we know, this is quite a rare gene. So I think it's really guidance for clinicians locally, but whether or not they could be followed will depend on what resources are available.
Thank you, Mark. And another question is, because it's quite common, and maybe we'll answer it now. All the other cancers, I've seen questions around melanoma, like skin cancer, cervical, any other gynecological cancer, thyroid. I appreciate it's limited research, but has that been considered?
Yeah, so we have looked at some cancers. We looked at prostate cancer and colon cancer, and we didn't find any increased risk. There's a hint that there may be some link with prostate cancer, but it's not necessarily an increased risk. It may be linked more with more aggressive cancer once you get the cancer. So I would say that, and looking at the pedigree, all the family trees that we have of all the patients, we have 1,300 of these now. We're not seeing any other cancers being hugely overrepresented. So I think if there are risks for other cancers, they're likely to be quite small risks. And often it's quite hard to then determine whether those are true or whether those are just chance findings. So I think in general, people could be reassured that we really are talking about, mainly breast cancer. We now have some good estimates on ovarian cancer and pancreatic cancer. Other cancers, probably, there's not going to be a big increased risk. If there is one, it's going to be very small and probably not enough to do anything about.
Thank you, Mark. Now we'll move on to Andrew to talk about the new treatment options.
Hello, everybody, and thank you very much for the invitation to join you today. Forgive me if I sound a little bit croaky. I hope my voice will last the 10 minutes and into the Q&A. So if you can give me my first slide, please, Mark. So I'm going to be talking about some targeted therapy options. And particularly I'm going to focus on the recent, on the development of PARP inhibition as a strategy and its relevance to BRCA1, 2 and PALB2 mutated forms of breast cancer, and therefore occurring in those who carry faulty copies of the gene. So this schema really just shows, and I think it's important to illustrate this before I go on to how we target mutations, that the BRCA1 and 2 genes, and this is also true for PALB2, we have 2 copies of each of these genes in our genome, and if you carry a faulty copy, you still have a normal copy of PALB2 or BRCA1 and 2 in all the cells of your body. You just carry 1 faulty copy and 1 normal copy. And that means that PALB2 is working normally in all cells of the body, but you've only got 1 backup copy, really, preventing cancer. Next slide. And so what does PALB2 normally do when it's functioning? So this is obviously a busy and rather sciencey slide, but in a nutshell, what it's illustrating is there's a complicated process. At the top of the slide, you see damage can occur in what's happening to our genetic code, all the time, and a series of proteins detect that damage, and they call in BRCA1, and BRCA1 kind of calls in PALB2 and BRCA2 to engage something called homologous recombination, which is a fancy way of saying it searches the genetic code to find an identical sequence to the one that's damaged in order to use it as a copy. And it then does a nice photocopy job of that normal sequence and replaces the damaged bit with the normal bit, and everything is good. But if you don't have your BRCA1, BRCA2 or PALB2 in this linked up way working properly, any of those not working leads to problems. Next slide. So those problems mean that whereas on the left-hand side of the schema, you can see we've got 2 nice, clean, normal copies of all our chromosomes in a cell in the breast, and in particularly breast in PALB2, as you've heard, but breast and ovary in BRCA1 and 2. When this goes wrong, the genome kind of gets a bit scrambled up, and that genetic set of instructions becomes pretty faulty pretty quickly. And that means the cell gets all of the other deck of cards of mutations it needs to become a cancer more frequently and more quickly than would normally happen. And that's why there's a higher rate of cancer and at earlier age when these genes go wrong and the normal copy gets lost in a target tissue. Next slide. So the Achilles heel that then comes with that is that those cancer cells that developed because they had this DNA repair problem also have an unprotected heel. Their DNA repair process isn't working properly. And we've discovered that drugs like platinum chemotherapies or drugs that inhibit an enzyme called PARP cause a type of damage when DNA is copied, when cells proliferate, that really needs those BRCA genes or PALB2 to work. And so while those drugs don't cause a big problem to the normal cells of the body, the cancer cells have this Achilles heel, and you can use the drugs to specifically target that Achilles heel in the cancer cell. Now that's relevant to PARP inhibitors, I'll show you, but platinum drugs are now much more commonly used for some of these reasons in triple negative breast cancer, which we know is a form of breast cancer that women with PALB2 mutations can quite commonly develop. Next slide. So we showed now quite a long time ago that for BRCA1 and 2, there was a synthetic lethal concept. So that is the idea that we used a sort of IKEA. I don't know how internationally that term transfers, but in the UK, we buy our furniture from a Scandinavian shop, and sometimes it comes with the flat pack having all the right screws and bolts in it, and occasionally it comes and there's a rather faulty leg. And the top panel is showing you what happens when you've got the full flat pack. Everything's working, you've got all the legs of the table. All the repair mechanisms available to that normal cell, shall we say. And the PARP inhibitor may break off one leg of the table, but because the cell is normal otherwise and has got all its other repair mechanisms, including BRCA1/2 PALB2 repair, it copes fine, the table stays up, it's not a disaster. Below, the flat pack that didn't come with all its legs, i.e. the tumour that's missing its PALB2 or BRCA1 and 2, doesn't have DNA repair working normally. Now you apply the PARP inhibitor, the table cannot stand up anymore. So the tumour is specifically killed and the normal tissues aren't. And this was called synthetic lethality. Next slide. Now, what we now know is that actually PARP inhibitors don't just inhibit the enzyme, they trap it on DNA, and that's why some of this works. And we could take advantage of the fact that drugs were already in development in order to try and sensitize to chemo, but we could take that directly into a trial for patients with BRCA1 and 2 mutations and ask, would it specifically impact their tumor even without chemo? And next slide, you'll see the picture comes up showing that ovarian cancer patients who had already had a lot of other treatment could receive the drug and have shrinkage of the tumor. And that led to trials that compared chemotherapy treatments for breast cancer with PARP inhibitor treatments instead in those with BRCA mutations. 2 trials have now led to the licensing of these drugs, olaparib from AstraZeneca and talazoparib from Pfizer, for BRCA mutated advanced breast cancer. Other drugs have recently reported but not had licenses. So this is better, it would seem, than chemotherapy in preventing or delaying progression and improving quality of life in advanced metastatic disease. Next slide. Now, as Mark showed before, people have now begun to extend that, and there's lots of reasons from the lab why we'd expect, and I showed you why PALB2 is working with BRCA1 and 2. We now can show that these drugs also work in those patients who have mutations in PALB2 and have advanced breast cancer. They seem to be very responsive to the drug. The big trials haven't been done, but I think many of us feel that we should now push to extrapolate these results to those patients who sadly have metastatic disease but have a PALB2 mutation as well as a BRCA1 or 2 mutation. And so there's much activity in that area. Next slide. The other area in which we've wanted to work is trying to say for people who got early breast cancer, could we target this Achilles heel and reduce life-threatening recurrence in those patients? And so the Olympia trial was set up in 2014 as a multi-national collaboration, and we recruited 1,800 participants in over 650 hospitals around the world, and the trial finished accruing in 2019, and we reported it this year. Next slide. So the study asked the question, if you've got breast cancer and a BRCA1 or 2 mutation, and had all your sort of chemotherapy treatments because you'd got reasonably high risks of recurrence, would adding a year of the same drug we talked about before, olaparib, reduce the risk of recurrence? And what were the side effects of giving healthy people after their chemo such drugs? Next slide. This is from the patient language, inpatient language summary of the trial, which is available on the web. And what you can see is that roughly, we randomized the patients between placebo and olaparib, about 900 patients in both groups, and after a year of treatment, looked to see who had developed all the various forms of recurrence and what were the side effects like. Next slide, please. Now, this is what we call a survival curve, and I think one message is, unlike in metastatic disease, you can see that lots of people are still doing really well and surviving well without recurrence of breast cancer after their standard treatment. Those are the folk in the yellow, the pale blue curve there. But clearly the results are not good enough. Only 77% of people with this high-risk form of the disease were alive and well without any form of recurrence 3 years later. But if you had a year of olaparib, that curve is higher, that there is an improvement in survival free of any form of cancer recurrence. And that's about a 40% improvement in that outcome. At the top of the slide on the right, you'll see the side effect profile. So you can see that even with placebo in the blue, people do feel a bit nauseous some of the time, have fatigue, anemia and vomiting much less common. But this drug is not like taking Smarties or a sugar pill. You do get some nausea, you do get some fatigue, you do get some anemia and a bit of vomiting, but generally this was considered very tolerable, and the quality of life preservation was just as good on patient assessments of it for the olaparib as for the placebo on a global measure. Next slide. So we really need to study when this doesn't work, because I showed you some people are still getting recurrence, and they're getting recurrence even if they have a PARP inhibitor. And so what we're doing in the lab, and I work very closely with my colleague Chris Lord in London, we have a joint laboratory program where on the left we're studying in cellular systems all the ways you could be resistant to PARP inhibitors if you have a PALB2 mutation, if you have a BRCA1 mutation, if you have a BRCA2 mutation. And on the right, we're trying to integrate that, next slide, with what happens in the clinic, what really happens in clinical trials and in the clinic, and see of all the possible things that could be the explanation, what really does happen within the clinic. And we encourage those with BRCA1, 2 or PALB2 mutations to help us try and understand that by joining the program and maybe helping us give blood samples and access their previous tumor material. Next slide. So in a cross-London initiative, we're basically meeting people who've had these mutations, and we collaborate with others overseas so that while they're receiving platinum drugs or PARP inhibitors, we can take blood samples before and after, understand who's doing really well and why, who's doing less well, and try and understand why and develop the new therapy strategies, both in early disease, next slide, and sadly in those who do still develop metastatic disease. And we develop models in the lab from the tumor so we can grow the tumor in the laboratory and do lots of things to understand its resistance and sensitivity. Next slide. So in conclusion, losing normal PALB2 in a cell causes cancers to happen more frequently, but certainly in the breast, as Mark showed, much less commonly in other sites and at younger age. Homologous recombination deficiency, the cause of the cancer, is also a target for treatment with drugs like platinum, which are increasingly used in people with PALB2 mutations, and PARP inhibitors, which we think should probably be used more frequently in patients with PALB2 mutations, at least for advanced disease. So this has led to approvals for PARP inhibitors for the BRCA carriers, and I think we need to influence guidelines for the PALB2 mutation carriers in advanced forms of breast cancer. Olaparib is now recommended for high recurrence risk early breast cancer with a BRCA1 and 2 mutation, but isn't yet licensed. I have to point that out. But that process is underway. And I think we rapidly need to understand how can we transfer, or understand should we transfer these results in early breast cancer to those with PALB2 mutations, and work out and also work out why they don't work in those they don't work in, and solve it. And I think that's me done. And I'm grateful for the opportunity to talk to you and take questions. Brilliant lab. We work with clinical collaborators. My mentor originally, Alan Ashworth, who is still very connected to, and our funders. Thank you.
Thanks very much, Andrew. Sounds like exciting developments on the way. I just wanted to be available for PALB2 carriers.
Sorry, say that again, Julia.
I said exciting developments. We just want this all to be available to PALB2.
Sure, absolutely. Maybe we'll take some of that in Q&A. But yeah, how do we get there is a good question.
Thank you. I'm just looking at time. We're definitely not half an hour in, but I'd like to ask Jen to talk about what we developed in the UK as information.
All right. Hi, my name is Jennifer. I'm a genetic counselor at the Royal Marsden Hospital, and all of us on the panel today were working together to develop a patient resource. I think there's some slides, Mark. We wanted to provide some information where lots of information was available in one place, and we based it on at the Marsden, we developed something called the Beginner's Guide to BRCA1 and BRCA2 about 10 or 11 years ago, and then we used that as a basis for doing one for Lynch syndrome. And so when it came time, when the new guidelines were published earlier this year, we got together and thought, well, let's take that as a basis for developing a resource and adapt it so it's specific to the risks we know about with PALB2 and to the situations and the cancers that are specific. So it is all written and agreed and tracked, changed accordingly.
Sorry, Jen, do you want me to advance the slides, or?
Yeah, you can pop them up because it's.
Okay, I've got the
which one?
Table of contents. What does it mean by the PALB2 alteration? So now we're on the table of contents, if you want.
Are you? Okay. So we haven't got it as a collected as a PDF yet, and we're just working on getting it formatted, and then we're going to publish it on the Cancer Genetics Group website, and I presume on the PALB2 interest group website. Is that right, Mark?
Correct, yeah.
Yeah. And so the table of contents, this is just showing what's included in it. So sorry, I can't see my own slides, but the beginning is what does it mean to have a PALB2 alteration, and giving some background information. And then the next section is to do with PALB2 cancer risks, where we go through the risks to do with the breast, pancreatic, ovarian cancer and other cancers. And then there's a separate section just to do with men so they don't feel left out, all based on the guidelines that Mark was referring to earlier. The next section of the booklet is to do with how to share information about the gene with your wider family, based at identifying who's at risk of having it in the family, how do you figure out who those people are, talking about the testing process for people who've not had cancer but are at risk of having the gene, and how to talk to children and young people about what's going on and how to share information. And that was based on some evidence of people who are working with children and families with genetic conditions. And then the last section, we've just called it miscellaneous. So talk about issues to do around family planning. There's a particular family planning option called pre-implantation genetic diagnosis, which is a technique that can be used to avoid passing the gene on. There's some information about lifestyle advice where there's evidence to back that up, discussions around studies and trials, issue to do with insurance and genetic testing to do with the UK situation, options to, if you can donate blood or donate organs, is that still possible? And then a list of other places to get more information, and then a glossary of a couple of the terms that we've used. And it's really not meant to be read from start to finish, cover to cover. It's quite long, but what we hope people do is use it as a resource. So if you're looking at something on the internet and you're wondering how does that map back to what the doctors were saying or what they've said here tonight, it's a place for you to kind of have a basic resource to kind of go back to. So again, we hope to be publishing it very soon. We just got to format it and it will be available. And the plan would be for it to be reviewed probably every 2 years and updated accordingly, so that if you're using it and you download it, it should be a current copy. And so it's not going to be available in a printed format because it will become out of date and also just due to expense. But as a PDF, hopefully most people can have access to that. I'm happy to answer any questions.
Thank you, Jen. I think the question, one of the questions, when do we think we can publish it? Probably soon.
Really soon. We just have to get it formatted. That's our stumbling block. If anyone is really good at formatting, get in touch with me and you can help me.
Okay. Thank you very much. I think with that finishes our main session. So at this point, we will stop the recording